Good afternoon, everyone. Clinical lead and senior consultant, medical oncologist, and transplant physician, and CAR T cell therapy specialist in Gleneagles Cancer Institute, Gleneagles Hospital, Perumbakam, Chennai. Um, this is breast cancer. This is a cancer awareness month. This February, entire full February is. So we will be spreading awareness to the public and as well as all regarding the cancer management, what are the new updates and new advancements happening in this field. So to bring some good hope for all the cancer patients and their relatives. We all know that cancer is the deadliest disease. Still, even in this modern era of healthy care, we couldn't extend a good survival for all these patients. It is same as like a decade before regarding the survival, but we are able to extend a good number of therapies, a good diagnostic facilities. So early diagnosis is happening, and as well as after the early diagnosis, the minimal treatment is able to be provided. So all these patients without toxicities from the treatment, they are able to get a good outcome. That to cure is nowadays possible with all the minimal treatments if the disease is detected in a very early stage. Otherwise, if the disease is detected little in advanced stage or advanced stage, there the therapies may be little complex one, much more aggressive therapies may be required, and out of all, toxicities may be a limiting factor for most of the patients. We always will try to weigh the benefit versus toxicity. There is no such a treatment called a zero toxicity with absolutely 100% benefit. We always try to minimize the toxicity and maximize the outcome. In that way, in this healthcare, that too in oncology, lot of new advancements have made in view of surgery, radiotherapy, chemotherapy. By all these broader fields, lot of advancements have happened. With these advancements, we are able to minimize the side effects, minimize the toxicities, and maximize the treatment outcome. And that too, particularly, we are able to increase the cure rate. Only thing is, if it is advanced stage or high burden disease, then treatment complexity may be increased. Many number of cycles or highly aggressive resections may be required. By that, toxicity may increase. But eventually, we will also try to improvise the outcome by providing them a good cure rate. In surgeries, there are so many advancement happening. Less invasive surgeries, keyhole surgeries, robotic surgeries to achieve a good resection rate with lesser side effects. In the same way, in the field of chemotherapy, so many advancements have made, many new drugs have come. They all have um, lesser side effects and increased benefit rates, increased outcomes, improved outcomes. I like to talk about three advancements happening in this field of medical oncology. Usually, if we are talking about medical oncology, we come to know medical oncology means chemotherapy. There are plenty of drugs for variety of disease. There is no such one shoe is going to fit for all. Like that, It's not chemotherapy, it's not a single drug which is going to hit all the cancers. There are hundreds of drugs in chemotherapy field. Each drug is specific for each treating each malignancy, each cancer. For example, breast cancers, the chemotherapy agents used are different. For ovarian cancers, slightly that may be different. For head and neck, it may be little different. For lung cancer, it may be little different. Sometimes overlapping drugs can also able to give that good benefit. Chemotherapy is a kind of vague weapon. It is going to kill all the fastly proliferating cells in the body. That is why we are getting side effects too. For example, if there is equally fastly proliferating a normal tissue is there in body, eventually that can also suffer the same toxicity, same cell kill as the tumor undergoes, as the cancer undergoes. For example, if I want to point such a normal tissue which has a high proliferative index almost matching to cancer cell, I would like to bring to a notice that gastrointestines, blood cells, hair follicles, all are of that same kind, even skin. They have high turnover rates, high replication, high doubling time. Cells are each day the cells are produced and each day some amount of cells are replicating and dying. In that way, that is a fastly proliferating normal tissue that mimics the same proliferation rate of tumor. So, chemotherapy cannot differentiate these tissue, which is normal, which is normal. So, it is a vague weapon. It's a kind of bomb. It will be, if it dropped, it will kill all the vulnerable cells. Here, the vulnerable cell could be apart from tumor cell. It could be even a normal cell. This fastly proliferating normal cell. So, in that way, we may suffer some collateral damage. A person who is taking chemotherapy can suffer collateral damage in the form of hair loss, diarrhea, mucositis, oral mucositis or stomatitis, drop in the blood cells, WBC, drop, hemoglobin drop, platelets reduced, like that kind. But in the advancements happening in the field of medical oncology, in that way, we have got a new drug called targeted therapy. Some cancer cells are prone to express some targets on their surface or inside the cell. Those targets, if can be identified, and those targets, if can be druggable, if they can be hit by some medicine, yeah, that's a kind of missile, that's a kind of bullet. So any druggable target, if expressed by a malignancy, if by cancer, then easily that can be hit by our targeted therapy. In that way, normal tissues won't suffer toxicities which we have seen in case of chemotherapy. So that toxicities of normal tissue will be very much reduced when we use a precise weapon called targeted therapy. The other one of that kind is immunotherapy. Targeted therapies are there in the field of oncology for more than 3 decades. We have a quite good experience in handling them, and we have seen so many patients who received the targeted therapy to have a good extended survival, and as well as long-term follow-up data are also available. So we know right and left of most of the targeted therapies. It is we have quite good knowledge and experience in handling that. So we don't have to be scared of that new form of therapy. It's not new. It's way 30 years old. It's a good form of therapy. The next of that is immunotherapy. Immunotherapy, by its definition, it says that it's not some external drug which we are giving into the body to kill a cell. Instead, we are priming and reactivating our immune cells against the cancer cell. Our own immune cells are primed and reactivated against that cancer cell. That is the strategy. So it's not some external chemical which is going to act inside our body. It is instead our own cell which is going to be redirected to the against the cancer cell. So in that way, selectively it can effect. The only thing is it may be a little costly when compared to targeted therapy, but otherwise its side effect profile is very less. Improved benefits, improved survival rates, improved cure rates are seen with immunotherapy. Recently, there is a one fascinating paper literature which got released globally. In a clinical trial, they have tried this immunotherapy for a rectal cancer. 12 patients who got subjected to that immunotherapy had shown complete 100% disappearance of the tumor. That's a great milestone achieved in this field of oncology. It's a very good, promising uh, result, promising literature. After that, now that literature came into um, you know came by a decade before. Now, with that advancement in this past, solid tumors are treated with immunotherapy. Non-operable high burden disease are converted into a operable with this immunotherapy, and sometimes who got operated with high risk of recurrence are treated with immunotherapy and they are cured. Sometimes inoperable, incurable, advanced stage diseases are also treated with immunotherapy and shown to have good extended survival with very less side effect profile. That's very important. Its side effect is very less. Patient can conveniently take these immunotherapy drugs for a endless period of time till the drug is showing a good response. For advanced disease and all, we cannot cure them. We cannot, once for all, we cannot declare them cure. We cannot remove the tumor outside from their body. So what we can do is maximum we can control all the disseminated advanced disease and keep the disease in a low pace, controlled way, and so we can extend their survival. Here, if you are considering a chemotherapy, their side effect will be a limiting factor for long term control of the disease and long term ingestion of the drug. But whereas if you use immunotherapy, their side effect is very less. It's a autologous product, body's product. So it's not going to increase side effect, rather it will give you a long term good quality of life with good control of the disease. So in that way, we have treated so many patients with immunotherapy for various indications, and we have given them a good quality of life and a good extended survival. So immunotherapy is another boom happened in this oncology field. It's another milestone. We have capitalized on immunotherapy and we have given that benefit to majority of the patient. Next comes this bone marrow transplant. Bone marrow transplant is a kind of old treatment strategy. It's been standard for almost more than 50 years. Many patients have underwent bone marrow transplant. Bone marrow transplant, of course, it carries its own morbidity, side effects. There are two types of transplant. One is autologous, another one is allogenous. Autologous means when a disease is heavy, when there is advanced disease, we sometimes give high dose chemotherapy because that disease won't be amenable for a normal standard dose chemotherapy. For them, we may require a high dose chemotherapy. But when we give high dose, the major limiting factor is the collateral damage, that is the death of the normal tissue, and particularly the bone marrow residing blood cells. When these bone marrow residing blood cells are depleted, or when they are killed to some extreme, when there is a low count, then these patients are prone for acquiring severe infections, because if the blood cells are not there, then they will be left immunosuppressive. They may not be immunocompetent because their protective barrier, their protective bone marrow cells are destroyed by this high dose chemotherapy. Then they will be vulnerable for acquiring infections for them, and as well as they will have low platelets that can also be prone for bleeding diathesis. For them, immediately we should give some cells to rescue their body. Otherwise, their own production by the bone marrow will not be appropriate, will not be helpful to handle the situation. The patient will be in absolutely a crisis. So we need to support the body. For that, we need to transfuse a lot of WBCs and platelets, but that is quite not possible. So, what we will do is, if you are planning for high dose therapy, then we may collect their own hematopoietic stem cell from the bone marrow just prior to high dose therapy, and we will freeze it in a freezer. And when required, we will defreeze. We will thaw that and we will re-infuse that into the patient's body. So patient's own cells are collected, own hematopoietic stem cells or bone marrow cells are collected, and if it is re-infused into the patient's body again after the high dose chemotherapy, then that is called autologous stem cell rescue. The other one is allogenic bone marrow transplant. Allogenic means the bone marrow cells are obtained from some other person for whom it should be matching with the patient's group. If we are able to get a matched donor from that person, a healthy individual, if you are able to collect the allogenic cells, we will get those allogenic cells collected, kept it in a good freezing environment, and when this patient is requiring, we will transfuse those allo bone marrow to them. It is called allo bone marrow stem cell transplant. For whomever indicated, we will do such and such procedure. For most of the solid tumors, we may prefer this high dose therapy followed by stem cell rescue. For us, whereas for blood cancers, we will prefer this allo hematopoietic stem cell transplant. So they have proved their role in way of managing all these solid malignancies who are refractory to chemotherapy, standard of care chemotherapy, and as well as to the relapsed refractory leukemias or upfront leukemias after the induction therapy. For high risk relapse patients, we have tried this allo transplant and cured them. We have good data, literature support over the period of past 50 years, and it has been proven a successful modality to cure certain specific populations with accountable side effects. We have to be very carefully selecting patients who can benefit from this transplant, and we have to support them with this transplant. In the way of the transplant, we have a new advancement called CAR T cell therapy. CAR T cell therapy, chimeric antigen receptor T cell therapy. Like I described, similarly, patient's immune cells, T lymphocytes, the patient's immune cells, T lymphocytes are collected from the patient, and they are manufactured, they are prepared in lab as a enhanced T cell, that is called CAR T, chimeric T cell. Patient's T cell are collected and they are activated into a active T cell, chimeric antigen T cell, enhanced effective T cell, and they will be reintroduced into the patient's body to fight against cancer. In that way, this augmented, enhanced T cell, patient's T cell, has proven worth to kill all the malignant cell and to increase the patient's life. These CAR T cells came into the treatment armamentarium and joined its hands by last 5 to 10 years globally. And now, with the past 5 years, we have even our own Indian manufactured CAR T cells that has come down with all the way of its cost effective, less costly, cheaper when compared to the US CAR T cell therapy, and that has even proved similar worth to the US based CAR T cell therapies. It's similar in its efficacy. So cost effective and good, equally efficacious. That we are giving it in our clinical hospital. We have extended that therapy in our hospital. All the relapsed refractory lymphomas and relapsed refractory leukemias are currently treated with this CAR T cell therapy. It has proved its role by curing them. Our patients have survived more than 5 years with that treatment with CAR T cell therapy, and worldwide we have experiences like patient who got first treated with this CAR T cell therapy are surviving now for more than 10 years. Our patients have survived beyond 3 years. So in that way, CAR T cell therapy is a very promising therapy for all these lymphomas and leukemias who is not obtaining some benefit from our standard of care chemotherapy. So relapsed refractory progressive lymphomas and leukemias can effectively be treated with this CAR T cell therapy, and it is worth to save their life. So I think these are all the major advances happening in this field of oncology, and I would like to bring it to your notice that these therapies, these are advanced treatment facilities are available in our clinical hospital. We have a good team, transplant facilities, CAR T cell therapy facilities are available. So with all these, we are able to provide a good life with preserved quality of life to all these cancer patients. Hopefully, you can all get benefited from this new advances happening in this field. If you have any further questions, I will be very much pleased to answer all these questions.